Welcome all.
Okay, thank you. Can I just remind everybody that the meeting is being recorded and will be placed on websites for public viewing. And I'll now take a roll call for the minute. Councillor Lynn.
Present.
Councillor McHugh.
Present.
David Cheap.
Present.
I've had apologies from Vicky Irons. Dave Berry.
Present, Arlene.
Christine Jones.
Present.
Sanjay Pillai. Lynn Lloyd.
Present.
Jocelyn Lyle.
Not present, but substituting for Barry Hudson.
Okay, thanks, Barry. Raymond Marshall.
Raymond actually gave his apologies to me.
Oh, did he? Okay, thank you. And we've had apologies from Martin Sloan. Okay.
Sorry. Yeah, sorry, I beg your pardon. It was Martin Sloan that gave his apologies to me. Sorry.
That's okay. Okay, so that takes us on to item 1, which is apologies, which have been noted. Item 2, declaration of interest. Are there any declarations? No. Okay, item 3, which is the minute of the meeting held on the 22nd of May, which is submitted for approval.
Are there any comments on the minutes? Can I just say, we normally use the raised hand function in this meeting. I've never had any problems, although I know that in other meetings you use the chat function if someone wants to ask a question. But yeah, there's Helen's. No, yeah, it's working. So unless anyone has any objections to that, if the raised hand function doesn't work for them, I'm happy to use that. And I don't see any raised hands. So yeah, these are accepted.
Okay, that takes us on then to 3B, which is the action tracker, which is submitted for noting and updating.
Any questions on this? Yes, Dorothy.
Thanks, Ken. The first one, which goes back to originally December 2022, it's so long ago. And I'm not sure from the action point and the status, what is this about?
Yeah, it's certainly a very long time, almost 2 years, to be having discussions about something that's maybe not that clear. Maybe could someone comment on that, please? Dave.
Yeah, I'll comment if that's okay. With that, thanks. So yeah, that's absolutely right. This one's taken a kind of long time to come to conclusion. I've kind of made the commitment that we'll get this one concluded either way by the next meeting. Where it kind of came from to start with was it doesn't really kind of happen very often, but there was some kind of a briefing sent out in between meetings. And I think the discussion at the next meeting is whether that should then become part of the sort of formal notes or formal minutes of or formal papers of the committee. And that's really what that action point is around, is whether it should become part of the formal papers or not, because it didn't form part of the actual meeting itself. So it's just one of these ones that keeps kind of slipping. Because the discussion, there has been initial discussion about it, but not follow-up. So I'll make that commitment and I'll pick up with Roger Many to confirm the process going forward.
So we would certainly hope to have that resolved by the latest date then, which is November. Yeah.
Yeah, the next part, by the next park meeting.
Yeah, that's what I mean, yeah. Yeah, David.
Yeah, it's more of a process thing, Ken. I just think, you know, being a councillor as well, I know how slow things work within councils, but it would be quite good if we could just even set something that said that really within 12 months of being registered as an action point, we should have them all, because there's things there seeing it back to 20, you know, as far back as, well, before that, but by this time last year, there's still action points. I'd like to think that we'd have a year max if we set a target of that. So within 1 year, we've got nothing older than a year as an action point. Because really, if you've gone through full cycles and things, we really should have answers and conclusions to these within a year.
Yep. I totally agree. So what you suggesting then, if we get to the stage where something's at a year, we either strike it off or demand immediate action, or?
Well, I just think we need a reasoning why. I mean, I think more as a board, we should agree, or as a committee, we should agree that a year is sufficient for an action point to have been raised and to being referred to, consulted on and actioned, and just make that our recognised target. And if it's not actioned by that point, we need reasoning on the anniversary as to why not. I mean, I'm not trying to put anybody under pressure, but I think it's reasonable.
Yeah, I do too. Yeah, that's the real standout one there. None of the rest of them are red. There's other amber ones that actually look as if they're kind of completed anyway, like the action point 3.
But they are at their first anniversary, Ken.
November 20, number 3's coming up to the first anniversary, but
yeah,
it's in amber, although it says that dates for development sessions have now been issued. So why is that amber, Dave? Why is that not just green or taken off?
Well, I see Catherine's got her hand up first.
Yeah, Catherine.
We just to be transparent, because we set the date, but the actual session hasn't taken place yet. But if you're happy for us to do it on the basis that the date's been set, they can. There's a number on there that would turn green on that basis, because they're all tied to development sessions.
Well, it's been achieved. If the date's actually been set, that's the action point being achieved, isn't it? Just kind of clutters up the.
Okay, we'll update a number of those then on that basis.
And then there's the one below as well, and I'm not sure about others, but. Yeah, terms of reference. Yeah, okay, there's a few like that. So, is there anyone else? But yeah, very reasonable point, David. Thank you. Dorothy.
I've got a question also on number 5, which relates to what the disparity in delayed discharge performances across LCPPs. This is useful information that's been provided in the status update, but it doesn't really answer the question about why there's a disparity across LCPPs, unless I'm not understanding the comments, the status comments properly.
Anyone? Angela.
Yeah, I can't directly answer that. Apologies, because this is my first meeting and I'm just still getting up to speed. I know Lynn is meant to be joining us shortly to talk to the unscheduled care paper. She might be able to answer.
Sorry, who was that?
Lynn Morman.
So she's coming in later, so we could perhaps return to that one later in the meeting then.
Okay. Which
is a bit unorthodox, but I don't have a problem with that if we can get your question answered, Dorothy. David?
Yeah, I just wonder again, I mean, I know there was 300 odd pages and I did literally go through them all for this meeting. I seem to think that was referred to in one of the reports looking at the local community plan, the LCs, but the local communities, that was referred to in that. So I think the answer might be in one of the reports further in this. It does say time frame September. I'm sure that was in the report.
Yeah, well,
I couldn't give Dorothy a direct answer what the answer is, but I seem to remember it being in the report.
Yeah, well, I certainly know that there's a breakdown between LCPPs and further reports, and that they do show a disparity. Pretty much as always, to be honest. We'll bring in Lynn Morman, though.
I'm happy to wait until we come to that report, just to save time. At this stage.
So perhaps, Dorothy, if you're not happy when we come to that particular report, you could just raise that again.
Yes.
Thank you.
Yes.
Are there any other action points that anyone wants to query?
Sorry, Ken, I saw Lindsay had her hand up there, possibly in response to that question. Lindsay.
Great stuff, thank you. It was just to update you that the discharge management paper, or the unscheduled care paper, doesn't have a breakdown in LCPPs, because that wasn't necessarily the focus of that paper for what we were trying to achieve. We do monitor the LCPP, excuse me, that's actually Lynn. We do monitor the LCPP breakdown through the quarterly performance report, and we have noted, and as part of the tracker, that there is an inequality across particularly West End for actually a number of indicators, which we have on our work plan to investigate further, and we have actually received the data for that. So we are looking at resources to prioritise, looking at that in more detail as soon as we possibly can. That helps.
So I help you, Dorothy?
Well, just to bring this to a close, I'm happy to take this offline with Lindsay.
Yeah, I think that's
It's
good.
always
idea.
very helpful with me when I've got queries.
Yeah, and then
Thank you.
We can move on from the action points. Okay, thanks.
Okay, so that takes us on to item 4, which is annual performance report, and this is for noting.
So yeah, very important annual document, as it says in the title, quite lengthy, but pleased to see that it's available in different formats and it's very readable and accessible to the public. I think 3 different formats. Who would like to speak to this, please? And then I'll bring in questions after. Dave, probably you.
Yeah, I'll do just to briefly introduce it. I'll pass on to Lindsay. So Kerry, you've kind of covered some of the things I was going to say. But I think you have before you the annual performance report for the IGB for 23-24. So just a reminder, this is one of our statutory reporting requirements. So we've kind of met our reporting standards for that in terms of timescales, etc. This one was, if you recall, originally on the IGB, but we didn't have sufficient time to kind of do it justice, so we've kind of put it on the Performance and Audit Committee as well for to provide an opportunity for further discussion. As you said, Ken, it's kind of really easy to read. It's kind of for the public. It's kind of public facing. So it kind of, I think it helps to kind of have that outward facing approach. And the fact that it's in different formats as well, so there's more of a sort of an interactive kind of format, with video, etc. So, and I think the fact that we've got it split down into the particular editions of the performance report as well, is helpful in terms of you're not kind of having to read through a 300-page document. There's kind of more sort of bite-sized, easy to read kind of areas as well. So I'll pass on to Lindsay now, because she'll kind of focus a bit more on some of the kind of key areas there. But so I'm just kind of pleased to see this one being brought forward, and thanks to everybody involved for pulling it together. It's been an excellent piece of work as ever.
Great stuff. Thank you very much. So, yep, just to follow on from what Dave said, we do quite a lot of work to make sure that we tick the statutory boxes about what the prescribed content is in the legislation. Also, ensuring that we're monitoring as much as possible the strategic priorities in our commissioning plan as well. And that's why we came up with the 3 editions that we did, to try and ensure that we're covering absolutely everything. But we are aware that in terms of the national outcomes, it isn't necessarily, it's not our only focus for the annual performance report. And it is really about making it sure that it's public facing, and as well as showcasing all the really good work in a context and a format that happens throughout the year. We are aiming to be as transparent as possible. So while we're giving examples of good practice, case studies, we're trying to include qualitative information as well as quantitative information. So where there are surveys and images and quotes, we're trying to bring that all to life in one document. Not in addition to that, we as I say, we're trying to be as transparent as possible. So we try to explain the challenges and the areas for further priority moving forward, and we also have a section on complaints and budget as well. So we do appreciate that it's long, and it's long because there's lots of work going on, and it's very difficult to pick and choose from that throughout the year at probably quite short notice, actually, when by the time we get to the end of the reporting year, we don't have much turnaround to actually get it published. So we'll do our best to try and showcase everything, but we would like to look at how we could cut it down in future years to make it even more transparent, and we're always looking at different formats of presentation, moving on from the 300 pages, you said, Dave, the 300-page PDF documents that we used to publish. We hope that using a SWAY format and having that available for whether someone's opening it on a smartphone or opening it on a PC is helpful, but with the addition of the PDF versions as well, which can be printed out and can be provided in alternative formats based on any requests that we receive. So we're hoping that we're ticking as many boxes and making it as accessible as possible, because it really is about what the members of the public are seeing as our main focus.
Yeah, although it's quite a lengthy document, it's not densely packed, and I think it's easy to read, and you don't get dissuaded from reading further because it's densely packed paragraphs. You know, a lot of the information in it is sobering, as ever when we're talking about Dundee. I mean, the demographics right at the start. Life expectancy is less than the rest of Scotland. I won't go on. I think you know what I'm talking about. And there, you know, one of our main focuses is on combating inequalities, and we still have. Dorothy was talking about disparities in relation to the last action point. We still have real disparities between the poorest areas and Dundee and the more well off. And you know, we should be seeing that the efforts we're making to tackle inequalities reflected year on year in this performance report to hopefully show that the inequalities are lessening. Is there evidence of that, anyone? Dave?
Yeah, I think it's a kind of really kind of challenging situation, because I think if we take into account, I mean, obviously we've been as an IGB in existence for 8 years, and that's always, you know, the tackling the health inequalities has always been a main priority for us right from day one.
Yeah.
But over that time period, we've obviously kind of had things like a kind of global pandemic kind of hitting us. We've had the kind of cost of living crisis as well. So I think there's the kind of the steps forward that we take, and then there are issues that hit us that perhaps kind of take things back. Excuse me again. I think because, you know, there's so many of our services are geared towards trying to kind of tackle the inequalities, but it's still a kind of smaller proportion compared to the kind of the other side of things in terms of, you know, the tackling the kind of high end, you know, kind of high intensity kind of care packages, etc. That it is really difficult for us to kind of continue to kind of shift in those resources. So it does give us a kind of significant challenge, but it doesn't mean to say we won't. No, we don't stop kind of trying to do that, and we'll continue to do that. I think it's quite difficult to kind of to evidence that a significant shift. I think there'll be small gains and small kind of movements around, but I think we just need to kind of keep focused on delivering on that priority.
Glenn, I don't know did you want to come in on that same point?
No, thanks, Ken. It was a separate question.
Okay, so I'll just take the questions in order then, and first up is Dorothy.
Thanks, Ken. I think it's a very good report, and it's very readable, you know, and 300 pages, you know, I've seen a lot worse. I think that's, you know, a great improvement in what's gone before. Thank you for everyone who's been involved in doing this. I have a comment on Appendix 1, page 35 of our bundle. I don't know what page it is in yours. It's the appendix headed introduction. On the page that includes the national indicators, a comment, first of all, we have 16 indicators and 10 with deteriorating performance, which is well, there's too much red on this report, as always. I don't like red, I like green. But my question, at the top of this page, it says that methodology was changed by the Scottish Government for 1920 survey, and it's therefore not accurate to compare results from before this survey. And yet, in the table, the first column and the second column in the table is improvement from 2017-18. So why are we reporting improvement or otherwise from 17-18 when we're warned that we shouldn't be comparing results from before the 1920 survey?
Fair point. Lindsay?
Simply because it's a statutory obligation for us to do that, to compare back the 5 years. So we have noted that the caveat that it's actually because they changed the methodology in the sample that's used for the survey. They previously included everybody, the whole population. Then from 2019-20, they narrowed it down to identify only people who received support from the Health and Social Care Partnership. It's a statutory duty for us to report the previous 5 years,
okay.
Which we have, but with the caveat that actually it's a slightly different cohort than, and we do have the health and care experience survey analysis further down on the agenda where I can go into that in more detail. And
no, that's fine, Lindsay. We'll soon be able, the 5 years will soon be able to take us to 1920 anyway, won't it?
Yeah.
Thank you.
David?
Yeah, thanks, Ken. This is only my second audit committee, and I looked at this report and kind of looked at it as a member of the public, still being fairly new to this as a kind of lay member, and it did read really well. I've got to say that, and it kept me interested virtually all the way through it. I still think, however, as an audit committee member, it's still too long. We have so much to actually read in not only this but all our other committees. It's far too long. There's pictures and photographs and things there that may interest members of the public and people who want to go into individual areas of it may be interested in that. But if you're looking at it as at an agenda point of view, when we start off, you just sigh when you see so many pages. I'll be perfectly frank with that. That aside, I think I say it wasn't a really interesting read. Matters of importance, page 23. However, I think the first two paragraphs there refer to 24-25, and it should be 23-24, I believe, on the number of employees who have left. It says 133 employees and 242 NHS Tayside left during 24-25. That should be 23-24, and the same for the next paragraph down, should be 23-24. That needs to get changed. And then just as a comment on page 26, when we looked at the actual expenditure, again, from a public information view, really good to get clear information figures like this broken down by area of spend. Really notable the almost 100% increase in spend on mental health over the last 5 years compared with anything else in there. And as an accountant, Dave will get this, just over the 5 years, it's good to see that there's an operational surplus over the 5 years. Now, I know that hides a multitude of stories and things, but that's good from that point of view. I mean, there's lots of things I could bring out in all the different elements of this paper that we're circling, but I'm not going to take up your time with all of that because it was more generalised comments, but it was very welcome. Like Dorothy has said, concerning there's so much red in these national indicators, and I know there's reasons for that, and there's looking at various elements of NHS Tayside, it's something similar at the moment, but it is a concern. That's all I've got to say on that at the moment. Thanks very much.
Thanks for that. Glenn?
Thanks, Ken. I think it's a very good report. I think it's well designed, well written, which I think shows the growing maturity and focus of the partnership. But there's references to staffing throughout the report, and the question I have is whether or not, based on the challenges that we're referring to, both current and expected, are we anticipating any challenges in relation to staffing capacity? with council and NHS staff, but also, of course, with third sector staff? And if so, how are those challenges being addressed and your risks being mitigated?
Yeah, and one of the issues in fact affecting capacities are really high levels of well, I think that they're high. Maybe we're no worse than the rest of Scotland, but one of them is like 12%, is it? That's different for the council and for the NH&SCP side. There's so many pages, you forget what page you saw things on, and I do take that point on board. Not just about this report, but about the entirety of the papers, which is 303 pages. It's clearly crucial that we have all the information that we need in these papers. But I think in order to be able to scrutinise properly, we probably have to have them distilled down a bit, which I think is what David's maybe saying, without missing out the crucial information, maybe just distill them down a little bit more, so that, because to try and pick things out at 303 pages in the time that we have available to us is difficult. Yeah, Jenny, do you want to come in on Glyn's point about capacity?
Yeah, it was just, I don't want to issue any spoilers because the workforce plan update will actually come to the next IJB, but it's just to say that that's probably where we detail everything we're doing to mitigate the risks in relation to workforce. So there are risks, Glyn, across all sectors of the workforce, and there's some particular hotspots still in terms of more specialist social care. So I would say learning disability and mental health are particularly challenging. It's a combination of work to support well-being and retention things, different ways of recruiting, linking in with universities, all the things that you would expect in that. And also, I suppose a fair amount of the work that's happening is also national.
Dorothy, I think your hand's up again, yep.
What do you mean again, Ken?
Oh, I just mean, yeah. Yeah.
Can I comment? David's point about 300 pages. Yes, I did sigh as well. But you get used to 300 or 400 pages. But it is a challenge. It really is a challenge. And if you do like I did this time, was procrastinate until yesterday. I spent 8 hours yesterday on these papers. That's my own fault for not scheduling things properly. But yes, it is a challenge to see that huge, big, fat envelope sitting in my pigeonhole when I go to pick up papers at council. I did want to make one comment on workforce wellbeing. There was a report came to council on Monday evening showing the absence rates across local government are increasing despite measures put in place to try to address this. So it'll be interesting to see the workforce plan that Jenny just mentioned coming to the IJB to see whether there's a similar picture there. That was all I wanted to say. Thanks, Ken.
Yeah, thanks. Did you want to come in to say in conclusion, Dave?
Well, I was going to comment originally, but on the point about the length of the papers, on that side of things, because I think we take on board those comments, and we'll kind of review kind of future meetings. I think that this meeting's got quite a lot of items on it. I think there's something about, because obviously the last meeting was in May, so there's quite a time period between the May and the September park meeting, so there's almost like an extra kind of set of papers on almost that comes through as part of that, and there are a couple of kind of, well, obviously the annual performance report. It's what it says. It's an annual performance report. We look at it once a year. It's quite a lengthy document as well. So that's taken up quite a chunk of that. I think we need to be mindful of that balance between having sufficient information to allow scrutiny for the committee itself, and also, if you can recall, a lot of the items that we do have on the agenda are as a result of either kind of audit recommendations or good practice, good governance recommendations as well. So I think we need to keep I can't kind of promise that we're not going to be able to take everything off agendas, because I think we then starts to undermine some of our governance, good governance arrangements. But we certainly can have a look at what we can do around agenda planning for the future.
I do wonder if there's an argument to go to 6 meetings a year as opposed to 4. Maybe if I think about that, maybe I know people's diaries are full, not just members of this committee, but obviously officers who have to compile reports. Maybe that's something that could be taken into consideration. David, again, just to be fair.
So there's only so many of us got to go around. Yeah, and I simply, honestly, you know, like people should know me by this. I'm not being critical of this. It's just I'm conscious of the fact, and I had this discussion with Bob Benson the other day of, you know, I'm sitting on the IJB as the IJB from a representative from NHS board, and now I'm on the health and social, the performance and audit committee for like the IJB. And I just think the two have to be different from my point of view. And I feel I'm almost reading a lot of information the same. So it's, you know, as an IJB, the papers I got here today would be the sort of thing I would expect to get the IJB, which is information effectively, useful information that can be commented on and questioned perhaps. But an audit committee, it just feels that we should have that level of reporting much more summarized, so that we are actually commenting from an audit point of view, rather than saying that, for example, that reads well and picking out odd bits and pieces. It's general commentary. It should be, we're also be picking up almost on the points that are necessary of audit, if you know what I mean. I may not make myself very clear, but it's not general reporting, and that shouldn't really be, I think, our aim here. It should really be the things that we want to question from an auditor point of view, an internal audit, rather than reading the same sort of things that we get in the IJB generally.
I had a similar short conversation with Bob yesterday. Bob's our chair, for those who are new today. And maybe that's something we could have a discussion about off table, because he was certainly singing your praises, David, in terms of your ability on the NHS audit committee. So
that's very dangerous. That sounds really dangerous. No.
A brief off table conversation, Dave.
Yeah, sure, of course. Okay.
But thanks for that, and thanks for those comments, David. I think for me, just kind of reflection that this isn't an audit committee. It's not solely an audit committee. It's a performance and audit committee. It's deliberately kind of set out that way, because it's not about audit. It's about this. This is the kind of forum that gives most of the IGB members that opportunity to kind of to scrutinise performance. I know we've kind of highlighted that in terms of, you know, some of the questions today around, you know, concern around some of the fact things haven't moved, that things are in reds, etc. So it does give that opportunity around performance. And if you look at the agenda, the majority of the agenda is around different aspects of performance, whether it's around, you know, the kind of service performance and the statutory kind of requirements that we've got around performance reporting. Some more specifically developed areas that again have been either at the request of the Performance and Audit Committee or as kind of developing areas. So we've got things around mental health indicators, drug and alcohol service indicators, so some very specifics around those areas, complaints and kind of feedback and also kind of risk management. So there is a kind of there's a wide range of papers, and the audit element is obviously kind of really important, but for this agenda there's obviously not a huge amount of particular audit issues. However, you know, obviously Barry's here from internal audit today in terms of the overall internal audit view and oversight of the kind of the workings and the governance of the IGB, the Performance and Audit Committee itself, with that array of reporting measures. Gives them the confidence that, you know, we are kind of covering the areas that need to be covered, you know, including clinical care, professional governance as well. So it's unfortunate the way that we are kind of set up, that we do have an awful lot of reporting requirements, covering a whole range of kind of services, because it is very complicated. And I do have sympathy with members who have to kind of read both council reports and NHS reports and IGB and PAC reports. There is quite a lot in there. All I can say is we will kind of continue to review what we're putting on the agendas to make sure that they are kind of relevant and they are things that will add value to the IGB and PAC.
Thanks, David. Dorothy.
I agree with Dave. You know, this meeting for me is about scrutinising performance. That's what, and I enjoy that. I think that's really useful, valuable role for us. It's maybe not necessary to have complete plans and complete, 300-page reports, because what we're really wanting to do is look at the numbers to see, whether they're, going up or coming down, or, going in the right direction. So I would like to see less papers, but I think there's some stuff that could be cut out. We don't need huge, copies of strategies and reports. Good that they are. But I enjoy this because this is a good opportunity to scrutinise just how well we're doing or not.
Thank you for that, Dorothy. I think we'll end this item on that note, which is for noting. So can we move on to the next item, please?
Yep, that takes us on to item 5, which is the Health and Social Care Partnership Performance Report Quarter 4, and this is also for noting.
Page 109.
Myself again, thank you very much. Okay, so the purpose of this report is to update the PAC on the 23-24 Quarter 4 performance against the National Health and Wellbeing indicators, but also the measuring performance under integration, as we call it, the MSG indicators. And we also now include data regarding the social care demand for care at home services using published available data. So in terms of what the key messages of what the data is telling us, well, we've already noted at this meeting that there's still significant variation by LCPP, with poor performance for many of the national indicators in the most deprived LCPPs. We have a statutory duty to compare with the previous 5 financial years. So 2018-19 up until 23-24 was our baseline. From quarter 1, it will move to 2019-20 as our baseline. So the performance is poorer than the 2018-19 baseline for the following indicators: the rate of emergency admissions for 18+, the rate of hospital admissions due to a fall for over 65s, emergency admissions, numbers from A&E for over 18s, emergency admissions as a rate of all A&E attendances for over 18s, 28-day hospital readmission rate, and rate of standard bed days lost to delayed discharges for the over 75 age group. The good news is that the rate of complex bed days lost to delayed discharges for over 75s was 25% lower than the 18-19 baseline, so that is a significant improvement. Moving on to the number of people who waited for the social care and care at home service. This data comes from the Public Health Scotland, which collates all of the data for all of the partnerships in Scotland, and they publish the data, and we access this published data to include in this report. So at the time of writing this report, the most recently available data was at the 24th of June 2024. So at this date, nobody waited in hospital, and 119 people waited in the community for a social care assessment. No one waited in hospital actually since 17th of October 2022. 11 people were assessed and waiting for a care at home package in hospital, and that amounts to 165 hours yet to be provided. 23 people were assessed and waiting for a care at home package in the community, and that amounted to 135 hours yet to be provided at that point. And for those already in receipt of a care at home package, there was a requirement for 128 additional hours, which had at that point had not been provided. Happy to take any questions.
David.
Thanks, and thanks, Lindsay, for a summary of that. Yeah, I think I'm probably no different to anybody else, and when I get these sort of indicators, I immediately look for the low figures and the very high figures of where we stand when we're comparing our position in Scotland against 1 to 31, and then obviously looking at page 115 to 117, it really worries me when I see us being so poor in comparative to others, in certain areas and here, and yet I applaud when we, it says we're sitting, first in the Tayside group position, whatever like that, which is obviously great. So I'm just, that's an observation. Obviously, you have concerns, and you try to dig a little bit more into it. The one thing I had a question on, Lindsay, and you may have addressed it there, and I was so busy looking through the pages that I didn't perhaps pick up. I talked about social care, and that on page 126 and also 128, we talk about the demand for care at home services. I'm just, I say apologies if you address this, but it's the spike in the graph again there at June 23, and I'm wondering if the spike upwards there is correlated to the spike downwards on the graph on page 128. Am I right in saying that?
Just comparing it to the
See Angela's hands up as well. Maybe Angela would like to comment on that.
Absolutely.
Thanks, Chair. Back in June 2023, there's a big piece of work that was going on with the Scottish Government to try and rationalise the way people were recording their data, because everybody across Scotland was doing something different. Right. And what we identified at that point was that because of some of the data quality issues that we have, when we're using new systems, staff are under pressure, such as under a pandemic. There was a lot of cases that were showing as sitting as over a certain period that we were fairly confident were not actually awaiting assessment. It was because the system hadn't been closed down properly. There was a variety of things that we started to do around that time. But what was agreed across Scotland was that everybody had to be doing the same thing. So it was agreed to mark it up rather than down. So we came up to the same standard as everybody else in terms of how we were recording that. There is still a piece of work ongoing at this point to make sure that two things are happening. One, the workflows are being closed down appropriately, because it's a purely a technical bit. If you don't hit the right button, it doesn't close it down. And the second one is around the way staff have been using Mosaic. So a lot of people have very complex needs, and because that is an almost constant assessment, they've been leaving the assessment open. Now, that doesn't mean they haven't had their assessment. It just means that it's changing so rapidly that instead of closing it down and opening a new workflow, they've left it open. So there's a big piece of work going on around that. And we think that that will start to show that over the next 12 to 24 months, once we've done all of that exercise and have a different way of working within the system. But that's why it suddenly spiked at that point.
And Andrew, just on the, thanks for that. And I can see that has then sort of levels out, so we're reporting on the continued same basis that way. Is that the same though for chart 4, the fact that it spiked downwards and has continued on at a low level on page 128 on the additional hours of care assessed? Is it the same reasons?
No, that was actually a very different reason. So that was around the time that we brought in a test of change. So again, through the pandemic, there was a few gaps in how we were working that was identified. So we started a new test of change with the resource matching unit and what we call enablement support workers. So it's very much a rapid assessment, rapid triage, working with our independent living review team to look at, is there a piece of equipment or something that would help that person remain independent rather than going straight to social care. And that had a massive impact on reducing the unmet need. There has been some increase in the level of hours that we're We're delivering though on the back of that, which unfortunately has been quite costly. So at this point, we're trying to balance out that need to keep the unmet need as low as possible, keeping our delayed discharges as low as possible, but balancing the books at the same time. And that's proving a little bit challenging.
It's much clearer. Thanks very much for your help with that. Thank you.
Dorothy.
Thank you. Thanks, Angela. It's smart working, though, you know, looking at different ways of dealing with these. And I know it's a challenge financially, but we'll get there. Well, fingers crossed we'll get there. I have a couple of comments on page 113, that's the sort of red and green table again. I see there's a 213% increase in the East End on delayed discharge bed days lost. Now that's huge. Is there any further information on why it's difference is as big as it is?
Yeah, Lindsay.
It's simply that numbers are small, so a small increase on a small denominator would amount to a big percentage.
Okay,
okay. 1 to 2 is 100% increase, isn't it? Yeah.
That's reassuring. Thank you, Lindsay. The other comment I have is on table 3, which starts at page 115 in my bundle, and it is on page 116, number 10. Percentage of staff, we say they would recommend their workplace as a good place to work. And I've never seen any information on this for the time I've been sitting on the IJB. I wonder why it's there. It maybe has to be there because it's a national indicator, but it's always blank. It's not available nationally. So it seems pretty pointless to have it there and never get any report on it.
It's true. It seems like it would be a simple enough question to ask staff amongst all the other questions we asked them. Lindsay, any comment on that?
We could create a proxy indicator from our staff surveys from each of the employers. However, this national indicator, it was in terms of a methodology for this, it's never come through. Could actually just remove that row and add a footnote to explain that, so we're not sort of giving sort of members additional sort of rows of information to read. But yeah, I think it was created with the best intentions, but never sort of followed through by Scottish Government.
Yeah, okay. I kept, hoping to see something in that row, but nothing's ever come. So that sounds like a good solution, Lindsay. Thank you.
Barry, would you like to come in at this point, please?
It was just that question rang a bell with me, and I think it's from an NHS perspective. It's part of their iMatter survey that's done every year. So from an NHS perspective, I would guess they'd be able to get DH&SCP figures from the NHS side for that KPI. It's just an observation. I'm just saying.
Yep, appreciated. Jenny?
Yeah, it's just to confirm if we can get it from iMatters, we use that for the whole of the partnership, not just the NHS.
Okay, anyone else? No, so I think we can now move on to the next item, given that that's also noted.
Yeah, it takes us on to item 6, which is the Clinical Care and Professional Governance Assurance Report, and this is for a decision.
Yes, who's going to speak to this?
I'm happy to speak to that one, Chair.
Yeah, thank you. Go ahead.
Okay, thanks. So this is the Clinical Care Professional Assurance Report for the Dundee Partnership, and as outlined in section 2.2, we're offering assurance at a reasonable level for the factors noted at section 2.2. It's got 2 or 3 areas just to highlight to the committee. Section 4.1 through clinical and care risk management. We are now starting to see very positively some improvement within our Dundee drug and alcohol recovery risks. Some of those are static between the last 2 periods, but over the last 12, 18 months or so, they have started to come down, and we're noting a continued improvement within some of those. The top one, number 1129, has remained static because we're waiting on national work to impact upon that one. But it's a really positive position for one of our teams that has been consistently having 4 or 5 of our top 5 risks in this section of this report for probably the last 2 years or so. So it's really positive to see the improvement. Some of the risks have now dropped out of the top 5, and that's really positive and testament to how well that team has worked. But it's just worth mentioning as well, it's not in the report, but the MAT standards continue to be measured and monitored, and the Dundee Partnership, I'm informed, was 3rd in Scotland in terms of how well they're achieving the MAT standards. So that team really is seeing a positive shift with regard to their risk and their performance. The perinatal mental health risk is sitting at level 20. However, I'm happy to say that that was a risk associated with accommodation. New accommodation has been sourced to meet the needs of that service, and that risk will be closed probably before the next PAC meeting. Workforce risk, I'm just mentioning this, I suppose, partly because of some of the earlier conversations within the meeting, but also because of the knock-on effect throughout this report. We was reduced from 15 to 12 risks associated with workforce. There are risks across all of our staff groups and across the vast majority of services. And clearly that has an impact on how we manage complaints, adverse events, our waiting times and so on. So while I'm not going to list that for each of the different teams, it's just to make note that they're there. But also, I suppose, and linking into the previous conversation that people had about the pressures of workforce and whether we'll know how risky they are, how the quality of the services are maintained. We've got a good track record within the partnership, I think, of raising when there are risks within particular teams. We've had the paediatric diabetes, the paediatric dietetic team, and we've had some community nursing teams, and when those risks are presenting, they are getting flagged up. So we've got good assurance that when those risks are becoming at a particularly high level, we should be aware of them and understand what the impact of those will be. Section 4.2 at B5, through our internal audit report, it was highlighted that some of the transparency about the reports going into our clinical care professional governance group could be stronger. So I started to list there where we've got the reports and the speakers, and we are building a planner and a tracker for that. So we'll make sure that we've followed that recommendation through. And then the final point that I just wanted to raise, a little way through the report, section C16. It's just on the overdue adverse events. And it's to note that there is improvement, but it is slow. And we recognise and understand that this is slow within the partnership. Certainly the historical incidents that do still date back to 2019 have improved. And in fact, in each of the 4 years after that as well, there's a small improvement within those. These are adverse events that are still having work done on them to get them to the point of being able to close them. They are our most complex and our most sensitive adverse events. They almost exclusively are dealing with deaths that we've had. And we've worked with the teams looking at those, and it's not just a case of getting them signed off wherever. It's just an administrative process that can close that off. That's been done, but the quality of the work and the sensitivity of the work that they're doing is actually giving me quite a bit of assurance in terms of the support that's provided to families, the support that's provided to staff, and the in-depth review and analysis that's undertaken to make sure that we've got the learning and the improvement coming through. So while that's not where I would like it to be, I completely understand why it's where it is, and there is movement in the right direction with that. So that's all I wanted to say, so I'm happy to take any queries or questions.
Thanks for that, Matthew. Particularly encouraged by the improvements in the DDAR service, because of course Dundee's had such a dreadful record in terms of drug deaths. So to see the Dundee doing so well, number 3 in Scotland in terms of achieving the MAT standards, is really encouraging. Just one little point. 4.2B5. There's 2 care homes in psychiatry of old age, no report or speaker. Is that just because there was no report to make, or that they didn't?
No, it was because no report was provided to that forum. That's supposed to provide a bit of context around that.
So one was expected there then, yeah.
Yes.
Because they're both. That's the 2 categories that are about older people. It's just a wee bit concerning then, and I wonder what was the reason.
Yeah, I think it was just the timing for the team in terms of people that were off from work at the time that the reports needed to be produced. It's actually quite unusual for that team not to do that, I have to say. And while this is the mechanism that we use as the main mechanism for our governance, we do have other mechanisms, management teams, but also there's a governance forum where actually that team is always present and do provide information. Yes. So there's a lot of information sitting underneath that. So I do have a level of assurance that the work is done is good. However, the expectation is that they support that meeting.
Yeah, absolutely. I wasn't suggesting that they'd gone silent for months on end. No, not at all. God, I was going to say Carolyn there. David, yeah.
Thanks again. Just 3 or 4 observations on this. One was a question, really. Maybe Matthew might be on. It's on page 134, talking about primary care sustainability, the strategic risk 1374, and the risk there of, say, providing primary care services in localities. Obviously, that's concerning reading that. I know the risk's gone down from 25 to 20, but when I read in the next paragraph, for the preliminary analysis of the survey indicates that 20% of Dundee practices consider their future sustainability to be at risk. 20%. What number of practices would that be?
So I think we've got. No, I'm not sure actually. Jenny, Angie, do you actually know the number?
It's just a rough estimate, you know.
It's in the 20s, Matthew, but
Yeah.
I'd be making it up if I said exactly. There've been a few changes, but you're probably talking 5 or 6.
Yeah, thank you.
It's still significant, which have a huge impact, clearly. It's worrying. Page 137. Let me just see why I'm saying that. Yeah, good to note the decrease in inpatient falls. I'll move on quickly. 139. On the other side of things, sad to hear of the increase in violence and aggression on our staff. And the last one I had was on page 148, and I'll move on to let Dorothy in. 148. Well, we've kind of referred to this a bit when we're talking about workflow. I've just picked up about I'm not on our the council. I've forgotten the term for it. Regardless, it's picked up today in the papers again about levels of sickness and absence in Angus Council, and it's really concerning right across to here in the public sector, particularly here as well. The high level of sickness and absence and vacancies here in this case on the community mental health team. Really concerned about the impact that of sickness is having. I know a number of the reasons, and we'll hear lots of them, but it's the impact of that I'm most concerned about, and thus the ongoing additional cost that has. I'm not sure where the solution to that is, but regardless, it's a concern for me. I think that was probably me. Thanks very much.
Yeah, thanks.
Thank you.
Dorothy.
Thanks, Ken. A similar point to one that David's just raised on 4.1b2, where it says 20% of Dundee practices consider their future sustainability to be at risk. I'm wondering where this comes from. There are less practices, therefore more patients per practice. Has this got something to do with that level of risk?
I think there are a number of factors that are involved in there. Yes, you're right. There are less practices. I think the supply of GPs is being challenged as well across the whole system. It's national in terms of that. So yeah, they're really struggling to have the bodies in to work that. Obviously, there's a lot of work through the Primary Care Improvement Fund to try and get other professionals to support the work of primary care, and significant work is being done with that. But it still leaves them in quite a perilous position. Jenny, do you want to?
Yeah, one of the biggest factors is actually trying to get premises and things sorted out in terms of that. That is one of maybe the bigger factors that stop people wanting to come into the profession as partners, is the risk that they take on in taking leases and things, and that's obviously caused nationally at the moment. It is, as Matthew said, fairly multifactorial though.
Okay, thanks. Another wee question I have on 4.2C1, adverse event management. Sorry, it's 4.3, adverse event management. And it talks about mortality learning event. What is a mortality learning event?
Yeah, thanks, Dorothy. That's a good question. So within the system, obviously we have a number of deaths that are reported, and historically people were asked to grade that event at the point of submitting that. And often that was wrong, because when we actually investigated that thoroughly, it would change further down the line. So a new option was put in to be a mortality learning event. So it's recorded as that, which allows the team time to review what happened and to review what level that needs to be investigated at, and then it's progressed from there. So it's just to sort of recognise those more complex adverse events that we get in a different way of managing them.
Okay, thank you, Matthew.
No more questions. Based on the content of this report and Matthew's comments, we're asked to provide a review on the level of assurance. I would suggest that we accept a reasonable level of insurance, not insurance, sorry, assurance. Is anyone otherwise minded? No, thank you.
Okay, so that takes us on to item 7, which is the quarterly feedback report, first quarter, and this is for noting.
So this is me. So just to say, it's the number of complaints that we've received in the first quarter remain quite low, really quite low for social work or social care complaints, and there's been a dip in the number of health complaints as well, so they're sitting lower than they have been. In terms of our performance, I would say that we are still kind of working hard to get them closed within timescales, and that's kind of reflected in the information in 5.7. So for stage 2, I think you can see that for the social work, social care complaints, we've closed 100% of them. For health complaints, that's 39%. So, but for the stage 1, the health complaints were 89% that we closed within timescales. So I think that kind of reflects the complexity of the complaints that we have. And that we are meeting regularly with our colleagues in the NHS Tayside Complaints and Feedback Team weekly to kind of make sure that we're keeping on top of that. Also, just like to draw your attention to the care opinion development work. So we have training dates sorted for the rollout of the training that we'll be having, and they'll be happening in October and November as well. So the care opinion team are mapping the teams that we have so that we can kind of start to use the system fully.
I certainly don't have it. Oh, sorry.
I think that's it. I think that's all it.
I certainly don't have any concerns about anything in this report. Low level of complaints, we're handling them well. Anyone else? David?
I'm with you on that completely. I've got a completely free report without any comments or questions. Thanks.
Oh, you've just ruined it though by comment.
Me too, I'll ruin it as well. I have no questions on this report.
I'm just going to ignore the pair of you. Now, next item, please.
Item 8 is the Strategic Risk Register update, and this is for noting.
So this is me again. I think just to draw attention to the only strategic risk that has increased was the risk on the, sorry, I'm just bringing it up. It was a finance risk. It was unable to maintain IJB spend. So that's increased up to a 25. And that's because we've now moved into financial recovery. So this is the only strategic risk that has changed since the last report. And just that we went over the strategic risks at the Clinical Care and Professional Governance Risk Forum as well. So that is the Strategic Risk Register.
Thank
update
you.
Briefly.
Yep. Dorothy?
Can someone explain to me, maybe Dave,
well, Dorothy, you're on mute.
What does it mean to enter financial recovery?
Oh, yes.
So our overspend position is further away from our planned position at the financial year end. It's a requirement under our integration scheme to develop a financial recovery plan. So we are in the process of doing that just now, and we will be presenting a financial recovery plan to the IGB at its meeting in October for the IGB to approve or otherwise in terms of the what we can set out within that recovery plan.
Thanks, Dave.
David.
Yeah, thanks. This is, I think, pertaining to my earlier comments, a really good report. You know, 2 or 3 pages of highlighted level things that shout out to you straight away where we have concerns. I mean, on the points, particularly from 5.2 to 5.5, it's very, very clear, and then it gives us a chance to look further down in the actual tables of the strategic risk back to August. But it's a really good and a straightforward report to read, again from an audit point of view, I think, and you know, but clearly concerning. We talk about staff resources again, and I know, and picking up on me already the impact of the half-hour reduction, that this is the impact and consequences that's going to have, although we know it's necessary, and of course the lack of capital investment. This is all stuff that's hitting us on the NHS Tayside board that we're so aware of. But just say, I didn't have any other questions on it, but it was a good summary report, I thought. Thank you.
Yeah, I agree. Yeah. Anyone else? No. So I think we can move on to that's also for noting. We can move on to the next item, please.
Item 9, Mental Health Services Indicators, Q4, and this is for noting.
Who would like to comment on this, please?
Great stuff. I'll make a start on that, and then I will pass on to Linda Graham to give the operational context and narrative around that. My monitor's just hung, so I'm just trying to find the paper. So the purpose of this paper is to report on a suite of measurement relating to the activity of mental health services for both scrutiny and assurance. I will summarise what the data is telling us, and I'll pass over. I'll pass over to Linda. I'm just trying to bear with me, please. It's actually hung. There we go. It's working now. Okay. So in terms of what the data is telling us, the rate of mental health admissions for the under 65 age group has increased across all hospital admissions and emergency admissions, and the rate of mental health admissions for the over 65 age group decreased. For both age groups, there is substantial variation by LCPP, with the most deprived localities having the highest rate of admissions. A similar trend that's followed through many of the performance papers today. The rate of mental health bed days for both under 65 and over 65 age group increased across all hospital admissions and emergency admissions. For both age group, again, there's substantial variation by LCPP, again, more deprived localities having the highest rate of admissions. We have benchmarked across the 8 family group partnerships, which we're aligned to through a local government benchmarking framework, and compared with Scotland. Well, Dundee has the 2nd highest rate of mental health emergency bed days for both age groups, the 18 to 64 age group and the over 65 age group. Looking at individual services, the number of new referrals to psychological therapies increased, with most new referrals coming from Lochie. So that amounted to 549 referrals. The percentage of patients referred to psychological therapies who commenced their treatment within 18 weeks of referral for completed waits rose quite substantially from 46% when we looked at Q1 21-22, and increased to 71% at Q4 23-24. Looking at the community-based mental health appointments from the Dundee Crisis team, the number has decreased. However, the number from the Dundee Community Mental Health West team increased. The number from Dundee Community Mental Health East team has remained constant over the reporting period. The number of people discharged without being seen decreased from 907 in Q1 21-22 to 458 at Q4 23-24. So that almost halved. The number of community-based mental health return appointments for every new patient seen is currently an average of 11. Moving on to psychiatry of old age, the number of new referrals dipped at Q1 22-23, but has since increased. And the percentage of referrals accepted decreased since Q3 22-23. So looking at Q4, the highest number of new referrals came from the Ferry, and the lowest number came from the West End. And again, looking at the average number of return appointments for every patient seen for this cohort of patients, the average is 12. Moving on to learning disabilities, the number of new referrals to learning disability services, again, almost doubled from 177 in Q1 21-22 to 356 at Q4 23-24. Highest number of new referrals came from Coldside, and the lowest number came from the Ferry. The percentage of referrals accepted, it decreased between 75%, from 75% at Q1 21-22 to 57% at Q4. And looking again at the average number of return appointments for every new patient seen, that was 11, and that's gone actually down from 18. It was sitting at 18 at Q1 21-22. Moving on to social work mental health officer team and the community mental health team for younger age groups has decreased during the reporting period. The number of new referrals to the social work community mental health team for older people actually increased from 131 to 189 between Q4 21-22 and Q4 23-24. And finally, the number of local authority guardian applications was 60 during Q4, and the number of private guardianship applications saw an increase from 53 at Q1 21-22 to 73 at Q4 23-24. So I'll pass over now to Linda to give sort of the operational context and narrative around this data.
Okay.
Thanks, Lindsay, and morning, colleagues. I won't add sort of much more. You'll be aware that we think about our services quite often in tiers or layers. So hopefully you will see in the report that our community access support continues to be utilised well. So Hope Point, our PAM service, and DBI. One thing that you will want to note is an important new sort of test of change that we have running with Scottish Autism, bearing in mind that we have long waits for our Tayside Adult Autism Consultancy team, and that test of change will allow people to access the service based on self-identified need relating to autism, as opposed to requiring a formal diagnosis. So there is no barriers to that. There's no door that people need to get through in order to be able to be suitable for that. There is no doubt that we continue to be challenged with service delivery, and as Lindsay's highlighted, is that all areas of our service, be that community mental health teams and psychological therapies, have a slow but growing referral rate, and that doesn't seem to be sort of tailing off in the way that we would have hoped. And then finally, I think in terms of our partnership staff, we continue to contribute quite significantly to the cross Tayside work streams that are taking place. And those are looking like some of the emergent models of care will line up quite nicely to us thinking much more about delivery of mental health services on the basis of our already existing GP clusters, but looking much more with single points of referral, and a move to maximising what partners can do in the delivery of mental health services, rather than what has been our reliance on our kind of highly trained health and social care staff to deliver that. So I'm happy, Chair, to take questions.
Yeah, thanks for that, Linda. On Appendix 1, there's an increasing trend for all three, all admissions, emergency admissions, and then the other one, rates per thousand. And the most recent quarter's got the highest number for all of them. I suppose I was wondering if there's another way of looking at that. You've mentioned Hope Point, you mentioned distress brief interventions. I'm wondering, has the fact that we have improved face-to-face services maybe led to more people ending up in the system that needed to be in the system, and that might partially account for what isn't a huge rise, but certainly is the highest in the last 4 or 5 years, well, 3-4 years. Linda, yeah.
Yeah, I don't think that's it. You know, we have a very established clinical pathway to and from Hope Point and crisis resolution and home treatment team. And actually that's needed very, very rarely do we have to step up care. So we're quite confident that the people that are presenting at Hope Point aren't people that should be accessing our more intensive mental health services. The data is a bit puzzling at the moment because it's also happening at a time where we have another test of change, I suppose, running with a crisis resolution and home treatment team, where anybody at community mental health team level who previously would have been referred for inpatient care, we're doing joint assessments with the crisis team in order that we can make much more use of intensive home treatment as an alternative to hospital admission. And that data is pointing to us actually getting a really significant reduction in the people who need to come into hospital-based care. So we would have hoped that that would have actually had a positive effect on the trend and brought it down the way. But it might mean that that's actually still targeting quite a different population, and that there is something going on about the people who are most unwell, almost getting to the point of being so unwell that they've gone beyond the point of insight and need compulsory measures to come in. So I can't actually explain it. I'm hoping it's just an aberration and we'll see the trend sorting itself out again.
Okay, thank you. Dorothy?
Thank you. Excuse me. A couple of things. Couple of well dones, first of all. Good improvement in the percentage of patients referred for psychological therapies who've commenced their treatment within 18 weeks. That's, you know, from 46% to 71%. That's excellent. And also in the number of people discharged without being seen, improvement in that area as well. I have a question on learning disabilities, 6.8 in the report. The number of new referrals doubled between 2022 and late 2024, yet the percentage of referrals accepted reduced in the same period. Could someone comment on that, please?
Do we have?
Yeah, I'm happy to come in. Probably only a kind of general comment, and it's one that pops up sometimes with our adult referrals as well, which is that when it looks like we're what gets entitled rejecting referrals, that can mean that people are already in receipt of care and it's a referral that shouldn't have been made. So we've recently, I can only give an adult example, Dorothy, but looked at some of our adult psychological therapies data, and something like 2/3 of rejected referrals are because somebody's already in treatment, particularly elsewhere in the system. So it looks like we're saying no to people, but it's actually because they're already in receipt of care. So I don't worry too much about the rejected referrals. The increasing rate, don't know, it may well be that it's a bit like the post-COVID adult rates, simply increasing similarly.
Okay, thank you. Oh, one other question, Ken, if I may.
Yeah.
On the Appendix 1 indicators, 197 in my bundle, number of new referrals to psychological therapies, all, has gone up from 1,300 in Q1 21-22 to 3,600 in 23-24. It's been gradually increasing, and now, you know, it's nearly 3 times what it was early 21-22. Could somebody comment on that, please?
Yep.
I'm happy to come back in again. So, colleagues, the referral to treatment target for psychological therapies is for 90% of people to be seen within 18 weeks. So although what looks there over the longer term like an improving performance, still wouldn't be seen as a satisfactory one. And actually we're one of 7 boards who've just been placed in what's called enhanced support, in order that we can try and improve our position. There is something, don't want to drown you in information, but when you look at the national data, psychological therapies in Tayside have a much higher rate of referral than other health board areas, and equally we have a much lower staff rate. So I'm trying to kind of offer wherever I go the fact that we've got any improvement in how we're doing is genuinely something to celebrate, even though we're not where we need to be. So we've got nothing to suggest that referrals are in any way inappropriate. You know, these are triaged at the point of referral, so it can only point to there being increasing levels of need in the community, and whether that's only COVID and related factors, or it's the ongoing, you know, decreased stigmatisation around mental health, that people are more willing to seek treatment. But it is a genuine increase, Dorothy, in the number of referrals that we're receiving.
Okay, thank you.
Glenn.
Thank you, Chair. I can see Jenny wants to come in as well. I don't know whether or not Jenny wants to follow up on Linda's points.
You, first, Jenny, sorry.
It's not going to be my most helpful, but if we don't really understand what's driving our demand position and the information we have at the moment, I suppose we're working with public health at the early stages around some of the modelling of demand so that we can better understand that. But I would say what's being experienced in mental health and psychological therapies is mirrored across the whole system in terms of increased levels of demand. What we don't know, I guess we hope that's a blip that does relate to COVID and starts to come down to a more level. It's whether it's going to be a sustained trend or not.
Mm-hmm.
And I just don't think we know the answer to that at the moment, but it is incredibly challenging.
Mm-hmm.
Thanks for your contributions. You know, for their hands, and that's for noting. I think, oh no, sorry, David, yeah. Or Glenn, I beg your pardon,
I think Glenn was before me.
Glenn,
No,
of course,
thank
you
you,
want,
thank
I
you.
don't know what's,
Thank you,
yeah.
Chair. I'm looking at page 182, paragraph 5.8, and children on the Child Protection Register, a third of their parents were registered because of parental mental illness. That's actually slightly lower than the national average from the latest available data, which was 39% across Scotland. But obviously it's still a concern because it has an impact in terms of physical abuse, emotional abuse and neglect. But I'm wondering whether or not we have or could gather any data on the extent to which those parents, carers were offered, had access to and engaged with mental health support. So it's the so what question, really. The data is helpful. A third of their parents had a mental health concern, but the question is, what did we do about it? Can we gather any data on whether or not they were offered and whether they accessed support, and if so, in fact, what impact that had.
Thanks for that. David.
Right. Yeah, I think going back to one of Dorothy's earlier points, yeah, there is lots of good news in this. I was picking up on, particularly on para 6.5 about the increasing percent of patients referred to psychological therapies. It's the good increase there. My point really, Chair, here is that I think para 6 in full and para 7 in full tell us virtually, it's a good summary, gives us all information we really need to. It's a good précis of everything else. The point I was kind of making in here, by the time I get to page 180 of this report, of this papers in total, I'm beginning to get weary. So by the time to have then 20 pages of graphs and data after that, when, as I said, para 6 and para 7 really gives us a good summary of everything, can I suggest that these sort of to reduce our papers goes into a link for us to look at when we want to see more data and details to support the numbers, because I doubt if I'm the only person who looked at graph after graph, seeing lots of coloured, graphs there, and I just switched off. I'll be absolutely frank to you on this one, because I read everything in 6 and 7, and that gave me all the information I need to know. So to reduce something by 20 pages and throw it in as a link for people to go into and look for more detail to support these, the narrative, I think would be a good suggestion. People may not agree, but that's my figure.
I don't know if I do or not. If we had purely, I mean, I've got them. The only time I ever have papers printed out is if I'm chairing a meeting, because it just kind of makes it easier for me. I always use the online version when I'm not chairing a meeting. And it's easy to access links then.
Yeah, I mean, that's what I'm saying. I'm using the online version to do this because it's great to be able to highlight
so
areas of
you would like
concern
a
or
link to
questions you want
that
to
then, rather than having to, I think that would make sense. Yeah.
Yeah, it means, I mean, everything's there in the narrative, and it's a really good narrative.
Yeah.
I'm not taking anything away from that, but then it gives you the chance to click on the link to expand on that, to look at in more detail. But to be fair, for the purpose of this committee, I don't need to look at all these graphs because I'm happy with all the information. But I would look at something perhaps in an area that is of concern to me in general context. But it's not going to change my decision on whether I'm noting this report or not. So I appreciate. We don't actually print out any papers anymore. Everything's online for us. But I appreciate other people will do that, and certainly as chairs, it does help. I understand that, but it would still allow you to go to the link and then print them out if you wanted to.
Yeah, sure. Can maybe take that on board when we're thinking about the next meeting, Dorothy?
I like papers, and it might be because of my great age, but I work so much better with papers. And forgive me, but I like the detail. The sort of summary in the report is someone's analysis, and I like to see for myself. I like to look at the numbers, and I really think it behoves us to look at the numbers in the detail. I mean, a link's a fine option, but it would worry me that some people just wouldn't bother looking at the detail at all. I like the papers. I can make all my notes and put my sticky post-its on them. I think it's important to look beyond what the report writer has highlighted as the main issues to be addressed within the report, because I might find something else that I think is equally as important but isn't in the highlights in the report. So I have to disagree with you, David.
Disagreement noted. I think clearly for paper versions you obviously can't click on a link, so we would need to continue to print these out. Yeah, it's something we can think about, I think, for the future when we're discussing agendas, etc. It's now 11:30, and I'm going to there's no more hands up, and that's for noting. So I'm going to have a 10-minute break, if that's all right with everyone. I'm sure it is. Yeah. So is the break now officially started? Now it's 11:30, so 11:40 we'll be back. Thank you. And it's now, yeah, time to restart.
Okay, so that takes us on to item 10, which is Drug and Alcohol Services Indicators, Q4, and this is for noting.
Page 209. Yeah, can we have someone speak to us, please?
Yep, that'll be myself.
Thank you.
Thank you. I'll make a start and then I'll pass over to Jenny to give the operational narrative stroke context around that. So the purpose of this report is to update the pack on performance of drug and alcohol services. In terms of what the data is telling us, the number of suspected non-fatal overdose incidents reported by the Scottish Ambulance Service and Police Scotland remained the same between Q4 22-23 and Q4 23-24. The proportion of people who started treatment within 21 days of referral has remained high, with only slightly decreased from 96% at Q4 to 94% at Q4 the following year at 23-24. The waiting time standard does continue to be met regarding this. The number of referrals for alcohol treatment decreased between Q4 22-23 and Q4 23-24. So it decreased from 638 to 586. And there was also a decrease in the number of individuals starting alcohol treatment from 638 to 535 over the year between the two quarters, 22-23 and 23-24. Statutory services are working to improve waiting times and we've experienced above average numbers of people disengaging prior to treatment. Number of referrals for drug treatment services increased between Q4 22-23 and Q4 23-24. So increased only slightly from 537 to 589, and the number of individuals starting drug treatment services increased by 23% during the same period. The number of alcohol brief interventions increased by 42%, quite a significant increase between Q4 22-23 and Q4 23-24. So went up from 996 to 1,415. The feeling was that the alcohol brief intervention delivery was significantly impacted by the pandemic. So the position is now beginning to improve, and there was an ABI coordinator appointed. So that's the reason for the increase there. The number of unplanned discharges where the service user disengaged increased by 38% over the year between Q4 22-23 and Q4 23-24. So that the numbers were 255 to 353. And finally, a note on the drugs deaths figures, which were published recently. So in 2023, there were 1,272 deaths due to drug misuse in Scotland, and this was an increase of 221 more across Scotland compared with the previous year. And in the Dundee context for 2023, there were a total of 46 deaths, and this is an increase of 8 deaths from 2022. Although it remains at the second lowest annual level since 2018. Obviously, we aim for the figure to be 0. After adjusting for age, Dundee City has the second highest rate of drug misuse deaths in Scotland, behind Glasgow, which has the highest rate. And that figure is calculated over the 5-year period from 2019 to 2023. So I'll pass over to Jerry to give detail on service improvements and priorities and the operational context.
Okay.
Thanks, Lindsay. I don't have a great deal to add to what you've said. I mean, I think that some of the things that I would kind of draw attention to, we've just passed the first anniversary for Hope Point, and a significant number of people with substance use issues are accessing that. We have work underway to develop pathways around non-opioid drug use patterns in alcohol, and some significant work with the third sector around things like advocacy and things like that. So a lot of work happening in the substance use area. And hopefully that's kind of borne out in terms of some of the improvements in things like the MAT standards. But I'm happy to just answer any questions around specific things in relation to the report.
Yeah, thanks for that. I'm very encouraged by the report, particularly the entirety of section 7, which describes the improvements that we have made and we're continuing to make, and the increasing involvement of people in services that probably otherwise weren't. We're scoring very well in a Scotland-wide context too, which is encouraging. And my hope, obviously, and the intention, obviously, is that we will see those dreadful figures, drug death figures, drop. With obviously the target, as Lindsay said, being 0. Dorothy.
Sorry, I was just taking a sip of my coffee there.
It's okay.
Excuse me. Thank you for this report. In what the data is telling us, I'm trying to separate out alcohol from drugs here. And I'm not sure at 6.6, the number of unplanned discharges where the service user disengaged increased by 38%. Is that for drug and alcohol, or does that relate to alcohol? That's my first part of my first question.
I don't know if you want to answer that, Lindsay. My understanding is it would be both. Lindsay, you're muted.
I think I need to go and check the data and get back, if that's okay.
Yeah, that's fine. That's fine. The second part of my question is at 6.7, drug-related deaths in Scotland in 2023. Is that just drug-related deaths, and is there any data on alcohol-related deaths?
Okay, so yeah, this is drug-related deaths only. Alcohol-related deaths are not sort of monitored, published in the same way. We could get that data and include that potentially. But yeah, this is only for drug-related deaths.
Okay, that it would be useful to, if a future meeting, we could have some further detail on alcohol-related deaths and the number of people disengaging from the alcohol brief interventions. Thank you.
I think that's absolutely right, and I have seen a figure recently in terms of alcohol-related deaths, and they were horrifying. Now, I think that may have been in the media. So if the media are able to get hold of that, surely we can, because they must be getting it from an official source. So that'd be really useful to have, so we can measure if things are getting worse, and if so, how much worse, and have a think about how we direct services towards addressing that. Do you want to come back in, Lindsay, or was that just a legacy hand?
Apologies, that's a legacy hand.
Yeah, I'll bring in David.
Yeah, so I was going to just agree with you, Ken, about all the good news, particularly in paragraph 7 you're referring to. Innocent lad here, but can somebody tell me what naloxone is?
Naloxone.
Not with any great degree of science, but it's an antidote to opioid overdose that's administered. So people carry it and you can give a sort of instant recovery to that. But if there's any of the GPs or anybody like that who's a bit more medically qualified to comment on that, they could give you a more detailed explanation.
No, that's more than sufficient. Don't worry, that's fine. So I wanted to try and the fact it was actually commented on in the table, particularly, that's why I was interested in it.
Can I just interject at this point? I don't know. I think you're making that sound a wee bit more complicated than it needs to be, Jenny. A lot of people, you can undertake a naloxone training course. You can do it online, which is what I did. and carrying naloxone as actually as I did, because I think I'll have to refresh the stock. I've never had to use it, but I think it's probably expired. But you can do an online training course, and they'll send you naloxone, and it's just a quick I don't know what the medical term, it's just a quick squish up the nose, basically, for someone who's passed out in the street, and you suspect it may be a drug overdose. Now, if it's not a drug overdose, I don't believe you can cause them any harm by administering naloxone, but it can certainly buy really crucial time in terms of getting someone to hospital, and it's been quite widely publicised. The naloxone scheme, and I would encourage all of us to do that training and to carry it. Lindsay?
Sorry, Ken, could I just, before
Yeah.
Lindsay speaks, just echo what you've said, and there's also a nasal spray, which is maybe easier to administer.
That's what I was talking about, the squish up the nose, yeah.
Yeah, and if you go into Hope Point, they'll give you one to carry in your bag or you put in your pocket. And I also would urge anyone to carry this with them. It could save a life.
Absolutely, David.
Yeah, the only other it's a question I had on this one. It was actually the very last indicator, number 14, on the spend on prescriptions generated by DDARS. There, just looking at the rolling figures there, from 600,000 back in Q4 21-22, going down to nearer 200,000. Is there a very brief reason why that is the case? Because it's obviously great for prescription costs to be going down, but just imagine there's something that's taken its place.
I can answer that.
Yeah, thank you, Lindsay.
It's not that they're going down. It's that it's a change in systems in the pharmacy service, which provides that data. So for this data, for the data set, we try to use rolling quarters, which is essentially given a whole year's of data so that we can compare quarters with years. At quarter 2, 23-24, the team was no longer able to, at that point, provide us with rolling data. So this is a standard for quarter 2, 23-24, quarter 3 and quarter 4, 23-24. It's standalone quarters, whereas if you look back at rolling 21-22, it is for a whole year. So discussed it with them, and actually we just need one more quarter for us to be able to just get back to the rolling quarter reporting again.
And it's going to be a much higher figure, clearly, Lindsay, as well in that case. Then, if you take the three quarters, we're already at more than 600 and something thousand for 3 quarters. So okay, that's interesting. Thanks. Yep.
Yeah, thanks for all the contributions on that item, which is again for noting. So can we move on, please?
Item 11, unscheduled care, and this is for noting too.
And that's myself with support from Lindsay.
Hi, Lynn.
Hi. And this report just asks the committee to note our current position in relation to both standard and complex delays, delayed discharges, and also the improvement actions that we're taking to address those. Worth noting before we start that we've made significant changes to this report for this meeting and tried to address some of the comments that have been made by the committee in the past. So we've moved away from some of the national verified data, which is one of the comments the last time, quite rightly, is that it's always going to there's always going to be a time lag and it's not live information because it takes time for that national data to be verified. So we are now using more live information, but just for noting that it isn't nationally verified at this point, although the level of scrutiny that I and others have over this data would suggest that it's as accurate as it possibly could be. So I guess notably, we have also changed the title because this has always been called a regular report on delayed discharges. We've moved this to now look at unscheduled care in recognition of the whole system approach that we're taking in Dundee and in Tayside. So just a note about the structure that we use. Much of this work around improvement and the monitoring of delayed discharges is done through our local Tayside Urgent and Unscheduled Care Board. I am currently the co-chair of that alongside one of my senior management colleagues in NHS Tayside. And it's agreed that a partnership rep we will rotate across Angus, Dundee and Perth and Kinross in that chair. So it's a demonstration of the whole system partnership. That board really works to identify and agree across the whole system the improvement measures that are required to address whole system capacity and flow, but also crucially delayed discharge. This year, the programme's got 4 key work streams. One is optimising access, and that is about creating very clear communication structures across the generic services out in community settings such as out of hours, NHS 24, Scottish Ambulance Service, to give them alternatives to just conveying the person to the front door of the hospital. So that's a very large piece of work, looking at linking up all of those communications and probably using our Consultant Connect service to do that. The next one is Performance 95, and that's targeted at improving flow through the emergency department so that the whole system works to meet the 4-hour national target. Community Urgent Care, which I'm closely linked to, really focuses on our urgent care service in Dundee, known as DECAT, Dundee Enhanced Care at Home team, and looks to link into the optimising access work stream as a really critical in Dundee alternative to conveying somebody to hospital so that they're receiving hospital at home and enhanced care in their own homes. And the fourth is optimising flow. And that's a continuation of the ongoing discharge without delay work, and really focuses on really good discharge planning practices and ensuring that every ward in the whole of Tayside achieves upper quartile length of stay against the national benchmarks for their areas in the national reporting. All of those work streams and the data packs and measurements around them are linked really closely to the NHS Tayside annual delivery plan, which is focused on obviously recouping some of the financial losses, but also trying to target very specifically improvement work. Key for us in the partnership is that we have signed up to deliver on achieving green RAG status against our delayed discharges against the locally agreed targets, as well as contributing to a 5% reduction, in admissions to the front door by developing our urgent care services. So there are a number of different actions that we take to try to ensure that we're delivering on that and reporting on it as well. Very senior management on daily management reporting of that RAG status across all sites. Happy to report that we have consistently remained in green in all our domains for several weeks now. We produce a weekly oversight report which provides data and information about the various services across the partnership which contribute towards this whole system unscheduled flow. We also have a weekly Tayside-wide discharge without delay key measurement, which isolates the Dundee data within it. We'll have our DECAT performance report, and we have a data pack aimed at looking at our community hospital, which in Dundee is Royal Victoria, and in particular, an improvement plan around their length of stay. Some of you on this committee will also receive my snapshot every week, which gives a little bit of narrative attached to that oversight report on our performance around delayed discharge in Dundee and any key issues that are coming up. So in terms of our current performance, the national indicator is the number of days people aged 75 plus spend in hospital when they're ready to be discharged per 1,000 of the population. So if you look at chart 1, that demonstrates where Dundee sits within Scotland, and I think we're in 6th position. So certainly in the upper half of that table for performance, with a rate of 428 per 1,000 of the population compared to 902 across Scotland. So performing really well, and well below the Scottish average. Performance has fluctuated for every year except 21-22, but every year apart from that year we have performed consistently better than the average across Scotland. There is, and I know there was some discussion earlier in the meeting about the performance broken down across LCPPs, and that comes out through our quarterly performance report that Lindsay referenced earlier. We haven't been able to break that down in this report because the numbers are so small that they would be identifiable, and so that's limited some of what we can report. In addition to that national indicator, DH&SCPs are also monitored against the rate of bed days lost per 1,000 of the 18+ population. And that's also included in the quarterly performance report that Lindsay presented earlier. So chart 2 just shows our performance against that indicator. And you can see that our performance is less than half the national average position and has returned to pre-COVID status. So again, performing very well against the national average. As part of our development and part of what we've brought into this report this time, we're looking at the average duration of delay based on type, age group and location, and happy to take feedback about whether that's more helpful than what we've reported in the past. So just some charts here that show what our performance is in terms of age, and then by type, and noting as well as noted earlier that some of these figures are so low that we've had to round them up. So actually the chart 4 graph performance is actually better than that, but we've had to round them up to 10 to make them non-identifiable. So this shows that most of the higher delays, the delays that are 28 days plus, occur in younger adults, those who are under 75, and that is mainly within our general adult psychiatry and learning disability wards, with where the discharge arrangements for people are far more complex. But noting also that there is a small but growing group of people in the acute hospital who are younger, who are experiencing delays, and we are beginning to see that significantly having an impact on our performance. Largely that is about people with complex physical health needs or with substance misuse issues, which mean their discharge from hospital is likely to be risky. Chart 6 shows the really significant impact of our social care performance in relation to delayed discharge. And you can see that as social care unmet need reduced as a result of improvement work in that area, our delays reduced almost exactly in parallel with the social care availability. So the average cost of a bed day is around £320. That means from April 2023, there was a potential cost pressure for NHS Tayside of 193,280 compared to April 24, where it's decreased to around just over 30,000. So quite significant improvement in our performance in relation to our partnership with NHS Tayside. Again, in terms of changing the language around delayed discharge, we've moved to measuring discharge without delay, and our national target there is 98%, and you can see in chart 7 that we have consistently performed either at that target or above. So actually a tiny percentage of our discharges are delayed in any way, and the majority of them go home without problem. And just section 9 is just really an outline of the ongoing improvement actions that we intend to take forward or are already working on to enable us to continue with this performance. Thank you.
So absolutely fantastic work that you've been doing, Lynn, and you have so many actions that you're focusing on to further improve services. That's a really impressive list of improvements, given the fact that we're already doing so well in relation to the rest of Scotland. And it's particularly important that people aged 75 plus don't spend any more time in hospital than absolutely necessary, because it's a very dangerous place to be in terms of infection control, etc. And yeah, just really well done. And I'll now bring in David.
Yeah, thank you. Lynn, congratulations. That's the good news written right through this paper. And I mean, as you say, Dundee has been sitting well in a lot of these charts regardless, but the fact it's improving, and the implicit cost reduction that brings is really good to read. Now, it's just me being thick, okay? But I'd circled this, or you referred to chart 1, and I look at the table and say, yeah, great, Dundee's in 6th position, but I can't quite get my head around the whole thing about what does the numbers actually mean when it says number of days.
Yeah,
okay, when ready to be just per 1,000 of population. I'm thinking, what does that tell me? I mean, it shows if we're great compared with other ones, but I've no idea what number of actual days in total are lost from that. Just per 1,000 population. Even as an accountant, I can't understand that, what that actually is telling me. That's the first question.
I'm going to defer to Lindsay to answer that question. Lindsay. Thank you very much. Okay, so this is the national indicator. So this is the government's metric to be able to compare each of the health and social care partnerships against each other. So it's bed days lost. So the clock starts ticking when someone in hospital is assessed as being fit to go home. So that the bed days lost counts from when someone is assessed as ready to go home to when they go home. And the numbers are totaled up and then divided by per 1,000 of the population for that age group. So it is complicated, and it's actually for that reason that we actually decided to actually take a blank sheet of paper when creating this paper for PAC, because we identified that actually to a member of the public and to the committee who aren't immersed in this data on a daily basis, it can be mind-boggling. So we did, when we were deciding on what to include in the paper, we received feedback to say, well, actually, how many people and for how long? Which actually makes sense. And you could understand it from a member of the public, actually that would make sense. That isn't as straightforward as you would think, because actually when we use census points, point in time for the number of people, and we use the entire number of bed days for the number of bed days. So you can't divide one against the other because one's using a census point. So again, that would be inaccurate. So that was the thinking around the further data in this chart. Obviously, we've used for chart 1, we've used the national indicator because that is a national indicator, but the charts that come after that are hopefully more meaningful to committee and to members of the public around actually what it means, whether it's bed days or whether it's number of people. And when we looked at, I know that we've talked already about why we've not gone into more detail about splitting up by LCPP. So when we had our meeting, discuss what to include, obviously that was on the table, and there was also about splitting up by age groups and also splitting up by the type of bed, whether it's an acute bed, a non-acute bed, or a mental health bed. Actually, we could have broken that down further, but we grouped up into these, again, to prevent identifying anybody and keeping, comparable groups. So the thinking was actually the narrative and the story behind the delays are more to do with the age group and more to do than the type of bed than to do with where in Dundee the person lives, which is why we went down that route. Not to say that we can't go in and do further dive into sort of the different LCPPs where people live, but the sort of professional discussion was around actually it's more to do with the complexities around different age groups and the trends between different age groups and the type of bed, which is why we went down that route for this paper. Does that help?
Yeah, Lindsay, listen, thanks. It's I get the point of the first question. I think I'll go back and look at the other charts that you referred to give me more the actual direct answer on numbers and things. But no, but all good news, as I say, and appreciate your response. Thank you.
Dorothy.
Yes, a good report. And David, I struggle with these numbers as well. You know, bed days lost per 1,018 plus population. And I've spoken to Lindsay about this, but you'll be pleased to know that there's a data analysis and understanding data development day coming up soon. So all will be revealed, let's hope. An excellent report showing an impressive improvement, especially in chart 2, you know, for the bed days lost, coming down from what for Dundee, 747.9, a rate of 747.9 to 428.3. Now, even if you don't understand what that number means, you know it's a huge improvement. I have one question, and it's on the last page, I think, of the second last page of the report. 9.1, where one of the bullet points, about 1, 2, 3, fourth down, talks about polypharmacy, and I don't know what polypharmacy is. Please.
I do. Do you want me to answer?
Yeah. Oh,
no, you answer.
Okay, so
That's me smart. Sorry.
One of the key areas of improvement in the ADP is to look at polypharmacy review, and polypharmacy is when someone has multiple medications, many of which may interact with each other. And what we know is that 40% of frail older adults who are admitted to hospital have polypharmacy issues that are contributing to the reason for admission. So we've identified that as something that we really can target out in the community to try to do polypharmacy reviews, strip out the medications that have been layered on over time and not reviewed. That then increases the possibility that that frail older adult will be able to cope at home without admission, but it also hopefully then saves money on our medication budgets as well. So there is a targeted piece of work by our Medicine for the Elderly consultants to support their GP practices through the cluster model to try to carry out polypharmacy reviews with the relevant frail population. Does that answer your question?
Yes, and I fully, you know, understand and think that's a great idea. Thank you.
Absolutely. No other hands, and that's for noting. So thanks very much for that, Lynn. I hope you leave us buoyed by the enthusiasm we're showing for what you've been doing and continue to do. Thank you.
Okay, that takes us on to item 12, which is the Health and Care Experience Survey Analysis, and it's for noting.
Okay, that's myself again. Last time.
Are you busy today, Lindsay?
I know. You'll be sick of hearing my voice.
Not at all.
So the purpose of this report is to update the pack on responses from the 23-24 Health and Care Experience Survey. So this is a big survey actually, but it is used by the Public Health Scotland, Scottish Government, to provide measurement against National Health and Wellbeing Indicators 1 to 9. So it's a postal survey. It's sent out to a random sample of people who were registered with a GP in Scotland, and the survey has been running every 2 years since 2019. So I said surveys used for to nationally inform and benchmark across partnerships, and the questions used for indicators 1 to 9 are just actually a small part of the survey. The survey is very large, and a lot of the questions in the survey actually relate to GP practices and about people's experience and access to GP practices. So this data is available both at practice and cluster level, and we have been having discussions about how we can make this data more accessible to GPs and GP clusters. We realise that busy people, that we want to try and do something with this data to sort of make it easier for them to access. So we're having these discussions at the moment. We're really want the data to be used to inform improvement. We realise it's not the only data out there. There's a number of other different sources of experience, care opinion being one, but the data's there, and it's nationally. The message is that it's it should be used to inform improvement. So we are trying to support this. We've already mentioned before that the survey methodology changed for all of the national indicator questions except for indicator 8, which is regarding carers. So whereas from prior to 2019-20, the questions asked the entire population about their experience of health and social care partnerships, whereas 1920 onwards they added a sub-question so that they could pick out only the people who are already receiving support from the health and social care partnership. So the data was more accurate, but it just meant that we can't compare longitudinally for prior to 2019-20, except for the carers question, because that is entire population data that's used. So we presented the data in 2 ways in the appendix. So by comparing the Dundee position to the local government benchmark and framework family group partnerships. So this is a group of partnerships which Dundee is aligned to because it was assessed nationally as having similar socio-economics or geographies to other partnerships in Scotland. Some of them are dubious, at Western Isles for instance, but that's the grouping that we've been given. So that's what we use to benchmark ourselves. We also have shown from 2019-20 the 3-year trend for Dundee against the 3-year trend for Scotland, showing it side by side to show where we have how we have improved or not over the last 3 years and how we compare with Scotland. So I won't go into every part of the analysis, but I'm happy to take any questions regarding any of this.
Yeah, thank you, Lindsay. That's a bit of an unusual survey in that it's exclusively paper only. There's no figure. I'm wondering how many of these surveys. I just wonder how useful the information is. Although I'm no statistician, I wonder how many were sent out throughout Scotland, how many were returned, what percentage, how many were sent out in Dundee, and what percentage were returned. Because if it was 1,000 were sent out in Dundee and you got 500 back, that would be significant. But if there was 100 sent out in Dundee and you got 24 back, I'm just wondering if we have any info on that.
Absolutely, yeah, that information will be available, but I don't have it to hand. Okay. But I do understand that the data is statistically significant, and that the sample of the population is representative of the population statistically.
Yeah, and they wouldn't release it unless, yeah, I guess I'm just being pernickety there. Yeah, I don't see any other hands. Interesting information, and thanks for the presentation, Dorothy.
Sorry, I put my hand up and then put it down again, so it's up again. This is interesting, and it would be useful. Although I take Lindsay's point, they wouldn't publish it if it wasn't statistically significant. But the numbers would be quite interesting. National Indicator 8, percentage of carers who feel supported to continue in their caring role. Really low scores here. 30 going from 27 to 36%, and the Scotland rate is around about just above 30%. These are really low scores. Does anybody want to comment on that?
Lindsay.
Okay,
yeah,
so this is these aren't just people who are already supported from the Carers Partnership and the Health and Social Care Partnership. This is the entire population, and they may be carers of children or carers of adults of varying sort of durations. We're expecting census data soon, which will give us the detail on the number of carers in Scotland and also Dundee, and the number of hours provided per week of care. So it doesn't, we know from discussions within the partnership that this figure doesn't correlate with data that the Carers Partnership holds and what we understand from the people who do access supports from the partnership and from the Carers Partnership. I would understand that it's wider than that.
Okay, thanks, Lindsay.
Yes, thank you again, Lindsay. And next item, please.
Item 13, Care Inspectorate Gradings, Registered Care Homes for Adults, Older People and Other Adult Services, and it's for noting.
This one's me this morning. So this is the annual report that comes to the Performance and Audit Committee, which summarises and analyses the Care Inspectorate gradings for services that are registered with them. So care homes for adults and older people only, and other adult services. And grateful to Rosguild from the contracts team who compiled this for us, and deserves all the credit for the report. So in the last year, 23-24, there were 69 inspections that took place in Dundee across 46 registered services. Those are services, some of which are provided directly by the Health and Social Care Partnership, but more commonly by organisations in the third and the independent sector as well. The report gives a little bit of background about the inspection regime, but I think what's worth mentioning is that it's constantly evolving. And although there is a real focus on supported self-evaluation within services as a part of a kind of wider continuous improvement approach, it's nonetheless quite a busy landscape, and it does impact on capacity within services in terms of responding to inspection, etc., some of which is unannounced as well. So I think there's a real kind of desire to continue to evolve the inspection framework, but I think it is recognised that it's a significant area of work that needs to be managed by the providers. Probably draw your attention to Table 2 at Section 4.2.2, which gives the overall kind of summary of performance over 23-24 and the comparison with the previous year. So some very positive news in terms of other adult services, where there's been a 21% increase in the number of inspections, which resulted in grades where they were good or above in all elements that were inspected. And also an 11% decrease in the number where grades were adequate or less. So overall, a good shift in terms of improvement in quality around other adult services. For care homes, though, a slightly different picture, stable in terms of the number where there was good or above, but there has been a 19% increase in the number where they were adequate or less, although you need to be cautious about that, because although it says 19%, that's actually only 2 inspections where that was the case. And there's significant further detail in Appendix 1 at page 251 about those 2 services and the support that's been provided to them. And also worth bearing in mind, there's been additional, since COVID, significant additional clinical care professional governance arrangements around care homes and support for care home improvement as well, to ensure that there's good oversight and good support to homes where there are kind of challenges around performance. The only other bit of the report I bring your attention to is in Appendix 1 at page 251. There's some detail there about high performance services, and I think sometimes we quite rightly focus on the areas where there's been challenges, but also really good to celebrate and recognise the hard work in services where there were excellent grades for them during that reporting year. Some of the things that have been said about warm, kind and respectful provision, skilled and consistent teams, person-led approaches, caring and compassionate are things that I think we would all want to see said about the services that look after really vulnerable people in the city as well. So really heartening to see that. And just to reassure you, there are lots of routes for that, sharing that learning, particularly through the kind of provider forum arrangements we have that are quite strong in Dundee and supported by internal staff, but also our Scottish Care lead Carol Brunton does an excellent job of kind of focusing on that, sharing the good practice as well as learning and improvement too. So I'll stop there. There's obviously a lot of detail in the report. I'm happy to take questions just now or off table. Angie and Jenny might want to comment, or Glyn from a Chief Social Work Officer perspective as well.
Yeah, thanks for that. There's a couple of care homes that particularly stick out. I won't mention them, but they're in the report. And see, when you look at what the requirements are, just really, really disturbing, particularly the requirement 1, which was given to one of the care homes for older people. By 19th April 2024, the provider must ensure that people are provided with meals, snacks and drinks which are appropriate to meet their needs. Why in 2024 is any care home having to be told that? That's an absolute disgrace. And I really hope that since April, 19th of April, well, there's another 4 requirements after that, but that's the one that really stuck. Well, the personal care, not good enough as well at requirement 3. Just awful, really. And that really I find distressing. Glyn.
Thanks, Chair. I think it's a good report, and I suppose the frequency of inspection activity mirrors the vulnerability of those that are being supporters, make sure that we're absolutely properly scrutinising the nature and extent of support. It's good to see the improvements, 21% have increased in terms of good or better. But it's 2 questions, and Catherine's alluded to it already, but do we have the capacity to respond to this level of inspection? And you've perhaps alluded to it as well, Chair, in terms of one of the houses in particular, which is fluctuating. Can we sustain progress in relation to that particular house without naming it? So it's capacity and sustaining
well, it's
momentum.
Named in the report. Yep. Jenny.
Yeah, I guess this is something we've developed over a number of years in the care home sector, because at a point in time it was so challenging. So what we have are huddles, link workers with every care home, and quite a big team that's focused on supporting people in care homes. The frequency of inspection, my understanding, it's the care inspector obviously that do it. I think that's statutory. We are able to respond to that, but it can be challenging to keep providers at a level, although we're talking about 2 and one of them has since closed.
Yeah, St Margaret's, yeah.
So in relation to that, I think the other one, process-wise, what we do is consider whether it's a large-scale investigation, it's contract monitoring, or what process would be appropriate to keep an eye on that. And there are a number of things we can do in terms of both offering support and in terms of, we could apply things like embargoes on new admissions and things like that. We can also consider through adult protection if there's anything else that we need to do. We would usually oversee one like that where there's particular concerns until the point that we're happy things have improved. So at this point in time, I could tell you that one's improved.
Okay.
Beyond a point where it's under those particular measures.
Good. Glad to hear that. Yeah, thank you. Something else I was going to say, but it slipped my mind now. Yeah, I think members, it was either the IJB or this committee, we were hoping that at some point someone from the care inspector could come along to probably it wouldn't be I wouldn't mind if it was an IJB meeting, they made a presentation, or whether it was a separate briefing system, just to enable members to have more of an insight into how they actually operate, what their inspection regime is, and how they work with the partnership, and etc. So yeah, I think that's been pursued. Catherine.
Yeah, just to confirm, that's on the schedule. I think it's the early December one, and we are just agreeing with the care inspectorate who will come and make a contribution to that as part of that. So it'll be partly our internal arrangements and partly their role. So hopefully that'll be helpful to members.
It will be, and it'll be really interesting too. Thanks very much for that. I don't see any other hands. So, next item, please, 14.
Item 14 is the Governance Action Plan Progress Report, and this is for a decision.
Oh, decision time, right? It gets interesting now, doesn't it? Right, who'd like to speak to this?
So I'll come in on this one. So yeah, members will hopefully recall that we've been doing a lot of work on the Governance Action Plan over quite a number of months. So our internal audit colleagues kind of did a really good job in terms of kind of pulling together all the different actions that were outstanding from internal audit, external audit, external scrutiny reports, etc. And over the last couple of months, our team's been pulling that together to kind of put it into well, it was known as Pentara system, to enable us to then kind of have a proper performance monitoring system attached to that. So so that work has now been done in terms of the input into the system. We have now got to the stage where individual managers have been asked to provide updates to each of the actions that are assigned to them to complete that, and therefore that will be available for us. That will be ready for completion and submission back to the November Performance and Audit Committee for members to have that kind of good overview and a proper updated position on the actions that are still outstanding on the governance action plan.
So the decision to be made on this one isn't really that interesting. It's whether or not to instruct the Chief Finance Officer to provide a full report no later than 20th of November 2024. I don't see why we wouldn't, but there may be some dissent. Maybe somebody didn't want a report, and I don't see any indication of that. So that's that recommendation at 2.2 is agreed. Thank you.
Okay, that takes us on to item 15, which is the IGB Internal Audit Plan Progress Report, and it's for noting.
Thanks, Arlene. I'll pick up a brief introduction with this one and then pass over hopefully to Barry to pick up any other specifics he wants to highlight for this report. So yeah, this is a regular report on the internal audit plan. So the appendix within the report contains the details of the various pieces of internal audit work and the plan that's currently in place, noting that most of the papers, most of the pieces of work are at a green rag status, showing that they're complete or on track. 2 are noted as red, which includes the governance action plan item that Dave's just covered just before this. And the sorry, lost my place there. And also the report also contains in 4.5 just additional assurance for the committee in terms of a number of other internal audit reports that have been undertaken by our partner bodies through the council or NHS Tayside, where these outputs are considered relevant for assurance purposes for ourselves. So I'll pass over to Barry to pick up any other specifics that he wants to highlight or raise from this paper.
Thank you, Christina. You probably stole my show with what you've said so far. The only thing I would like to say is that the summaries we provided from the audits around the partner sort of organisations, we are looking at ways to try and make these more succinct. We appreciate they're quite long as they stand, but we are sort of liaising with our council colleagues to improve that process. I really don't have anything else to add at this point in time, but I'm happy to take any questions.
I don't actually have any questions on that. Does anyone else? No. So, yeah, thanks for that, Barry. No questions, so that's duly noted.
Okay, that takes us on to item 16, which is the Internal Audit Plan 24-25, and this is for a decision.
Okay. And again, I'll just pick this one up as an introduction for it, and then see if Barry's got any further comments on this one. So yeah, an annual report in terms of the proposed annual internal audit work that is proposed to be undertaken through to the 24-25. Obviously, we're already a considerable bit of the way through this financial year. But this document just confirms exactly what the different pieces of work will be from our point of view. We are reliant, obviously, on internal audit teams within the council and NHS Tayside, as well as FTF and Internal Audit Services as Chief Internal Auditor. The resources are identified as being 40 days of internal audit work from the organisations. Majority of that work will be focused on the annual report and the internal control evaluation report, with one discretionary audit on lead partner services, with the hope that that will actually be looked at as a Tayside-wide report from all 3 IGBs. The report also asks committee to note the recommendation to continue the appointment of FTF internal audit team and therefore as chief internal auditor for 24-25. And Appendix 2 also details the updated internal audit charter, which PAC are asked us to note and approve as well. But Barry, you probably have some specifics or highlights that you want to pick up through the paper.
Yeah, I just want to say, just in relation to that audit charter, the committee considered it last year. The changes to it are very, very minor. If there had been quite a few changes, I would have presented it with a track change version for you. But because there were so few changes, we didn't do that. The only other point I would probably like to make is just this discretionary audit we're doing called Lead Partner Services. Hopefully this will add value by doing it across the 3 IJBs. It's already been agreed within the Angus IJB audit plan, and the audit's going to be led by the Dundee City Council internal audit team, and Perthink and Ross have also agreed to provide days to it. So it's a new way of doing some of these audits, but I do feel by providing a report across the whole of Tayside, it'll have added value and benefit to all the IJBs.
Thanks
Nothing
for that.
else. Yeah.
Any questions, Dorothy?
I don't want to make much of this, but the changes to the charter, you're saying that that were quite insignificant, but I just don't know what they were, and I don't want you to go into any detail at this meeting. But maybe I could email you to get information on what these minor changes were, please.
Yeah, no problem.
Thank you.
So we are asked to agree the recommendations at 2.1 to agree the continuation of 5 Tayside and Forth Valley internal audit, improve the internal audit plan and approve the revised and updated internal audit charter. Is that agreed? Thank you.
Okay, so the last item is the attendance list, which is submitted for information and record purposes.
Thank you. So that's the end of the meeting. One thing is for sure, I won't be chairing the next meeting. Whether I'll be a member of the committee, who knows? But I've enjoyed the last 2 years, and thanks everyone for coming along and for the contributions you've made. And I'd like to single out Lindsay today, who's done an awful lot of explanations of all the papers. Thanks very much for that. You put your hand up there, Lindsay.
Yeah, it was just to acknowledge that actually I'm part of a wider team now, so I was representing the team when I was presenting the papers. I didn't start and finish all of them myself.
Yeah, well, I know you didn't write them all yourself. No, you presented them though. So that's the business for today. Thanks everyone for your attendance, and it's a nice sunny day, so hopefully you'll get out and, well, not those of us who have other meetings like I do, but I hope the rest of you can get out and enjoy the sunshine. Thank you for your time.
Ken, can I just ask if you could stay on for a minute after?
Absolutely, yeah.
The rest will go off for a quick chat.
Can I check that the recording will have stopped by the time that David and I are having a private conversation?
Yep, I'm just about to stop it now.
Thanks very much for that. Okay, bye everyone, except David. Yeah.
Thank you.